Good evening, ladies and gentlemen, and to everyone who's watching us live from various parts of the globe. My name is Ruben Lobo, and on behalf of team DentistChannel.Online, I welcome and I warmly invite you to the world's first virtual Implant-Expo 2020. Ladies and gentlemen, it is said that the blessings of some people always remain with you forever. On the 13th of April 2020 at 11 a.m. Indian Standard Time, we started with a webinar. Not sure where we are going to lead. The webinar was conducted by Dr. Prafulla Thumati himself. Today, we have reached this level. I think it's only because of the first session and because of the blessings, the good wishes, and the prayers that we have of Dr. Prafulla Thumati. Dr. Prafulla Thumati has always been a mentor, friend, a well-wisher, overall, a person who's always said yes to any request that me or my team has always put forth to Dr. Prafulla Thumati. My heart is beating with pride because Dr. Prafulla Thumati was the first person who I asked and requested if you could present a small presentation. I know it's a very heavy, busy schedule for you, but still amidst everything, he said, yes, Ruben. And I think there can never be anything more special than having Dr. Prafulla Thumati, because what started as a one webinar today is successfully the 6th day of the biggest implantology event. Ladies and gentlemen, I am so happy, so privileged, and I feel so blessed to have with us Dr. Prafulla Thumati, the person himself who we really respect, admire, and we appreciate for the good work he's doing. That is not because of the dental cases that he's doing. That is not because of the vast experience that he has. That is because of his nature and his respect that he gives to everyone. Dr. Prafulla, we are so happy to have you. I think it's the biggest thing. I'm at a loss of words, to be very honest with you. I've been waiting for your session since the last 6 days. I will tell you from the bottom of my heart, and I can never be more happy than having you always and forever. It is only because of you and your blessings we have reached this level. And I know that you will always be there behind us no matter what. Ladies and gentlemen, a short introduction about Dr. Prafulla, because he really doesn't need an introduction. I don't know if there is anyone who doesn't know Dr. Prafulla Thumati because of the research he's been doing in occlusion and various other fields of dentistry. Dr. Prafulla Thumati, MDS, and PhD, is a professor and the head of the department of the Orofacial Pain Clinic at Raja Rajeshwari Dental College, Bengaluru. Presenting to you Dr. Prafulla Thumati once again live.
A very good evening to all of you. Shall I share the screen, Ruben?
Yes, doctor, please share your screen. Thank you.
A very good evening to all of you. On the eve of festivals, I would greet all of you. The God of obstacles, remove all the obstacles what we have for a normal living. This is a slide I use in all my presentations since last almost 10 years. The first slide which says, I talk in terms of Mother Nature, representing God, maybe any number of names we take in Hinduism, or maybe Allah, or maybe Jesus. But it is Mother Nature for me. I honor the place in you in which the entire universe dwells. I honor the place in you which is of love, of truth, of light, and of peace. When you are in that place in you and I am in that place in me, we are all one. Namaste to all whoever is watching across the globe. A small effort from my side in understanding occlusion. Being a prosthodontist from last 30 years, and after starting measuring the occlusion using digital technology, the advanced technology called T-scan and electromyography, now we have reached the pinnacle of literature to understand and help our patients in whatever the kind of restorative work we are doing, whether it is prosthodontic work or endodontic work or orthodontic work or implant work. And as at the outset, at the outset, I would like to thank and wish all the best to Dentist Channel Online, the entire group, the young and energetic group who are trying to put across a lot of things across to the dental community to help us learn and to share our little knowledge, whatever we know across each other. Thank you, the entire team of Dentist Channel Online, for having me today for this small presentation. Coming to distal occlusion in the workflow of implant rehabilitations. The word physiologic, which could be used either for materials or forces. As we go through my slides, you'll try to understand everything on earth has been done as far as implant protocols are considered, whether it is surgical phase 1 or restorative phase 2 time. So when it comes to forces, nothing was done. So it's time now we realize that, and using the T-scan tool and electromyography, we have distilled the occlusion, and that is where Dr. Robert Kirsten came up with the concept of delayed loading of the implant processes or maybe implant crown. That is where we are going to go through in today's presentation. And as I mentioned to you, everything in relation to implants, whether it is regeneration or implant therapy or smart attachments or bionic framework materials like your BPP or physiologically veneered restorative work. Every area was understood, and researchers and all those engineers and clinicians have put in a lot of work. But still, as clinicians at practice level, I've been practicing implants for the last 28 years. We have seen plenty of failures. But why? When so much of research work is going on, why do we see failures? That is where we need to understand occlusion, my friends. Whether in any part of dentistry, the occlusion plays a big role. So in the dental implant work, you have gone through implant therapy, regeneration, attachments, physiologic veneering, and bionic frameworks. But what about your occlusal forces? Occlusal forces were never thought of. We think about it, but subjectively we use one of the medias like articulating papers and try to manage or equilibrate or calibrate the occlusion subjectively. At the end of the presentation, you'll realize how important it is to do the work objectively by measuring. Today, we have all the facilities, advanced tools to measure everything, whatever we are doing in dentistry. Let's see what we are talking about. As far as implant science is concerned, you have clinically maybe a single tooth missing, multiple teeth missing, or maybe an edentulous maxilla or mandible, right? And a situation like this, a single tooth missing, you have a single tooth missing there. So situation like that, multiple teeth missing. Clinically, these are the kind of different situations we come across, right? So radiographically, one case to show multiple teeth missing. These are all the clinical situations you do come across. Edentulous maxilla or mandible. At whatever the stage of resorption, maybe type 1 to type 4, reverse resorption, any kind of clinical situation you might come across. Bone quality from D1 to D4, anything you might see, right? In a situation like this, you go through all kinds of imaging, all kinds of planning your treatment and execute it. Maybe conventionally or maybe by guided surgeries. But still sometimes we see failures. Why? Why? Because objectively we don't measure the time and forces delivered by occlusion. That is what we are going to discuss today about implant occlusion, my dear friends. So the options could be replacing a single tooth or multiple teeth, or implant supported tooth or teeth supported bridge, implant supported overdentures, or maybe fixed dentures, which could be either cement retained or screw retained. And in case of retention, the word when we use, you might be using bars, magnets, or ball attachments or fixed cemented or screw retained options. This is in glimpses, about 4 or 5 slides I thought I'll go through, then walk into today's topic. Once you know all these 5 core competencies which contribute to your success, amazing work done in the whole world in the dental implantology, still we see failures. Why? Why? Because we never respected the physiology behind the dental forces delivered by the occlusion, my dear friends. So that's what we talk about, physiologic forces against time. So these are the gadgets that we use. This is the T-scan hardware with electronic sensor. This is the electromyography with surface electrodes attached. And we simply ask the patient to bite onto this sensor. That gives us the data, which gives us solutions to all kinds of failures what we are seeing. That is what we call it as digital analysis of occlusion. When it comes to dental implants, what not is not being done. Everything, right? We have moved from generation to generation, right from rudimentary implants to fine perfected, biomechanically perfected designed implants today we have, right from short to long and any kind of diameter you look for. Maybe traditional implants or maybe mono implants or so-called immediate loading implants, they call mono implants, right? And coming to prosthetic options, the components, look at the kind of work done, whether it's implant design, when it's surface coatings or threads, or when it comes to attachment, prosthetic attachment, straight, angled, so many varieties we see, right? And even for UCLA, for custom made, now today CAD/CAM mill, everything, low profile abutments, whatnot. So you have all kinds of impression copings, replicas, and abutments when you want to do the prosthetic phase of the treatment. But when it comes to physiologic forces, that is where I want to discuss with you all about discretizing implant occlusion. Occlusal trauma refers to a response or an effect and is defined as an injury to the attachment or tooth as a result of excessive occlusal forces from the American Academy of Periodontology. Implant rehabilitations, a perfectly adapted occlusion is more important than in the natural dentition and dental supported prosthetic construction. I hope you understand the statement. In implant rehabilitations, a perfectly adapted occlusion is very critical because we don't want to see any failures post-prosthodontic phase, right? It is more important than in natural dentition or any restorative work you have done in natural dentition because of the following reasons, which I'm going to discuss with you all today. Implant-supported dentition has structures which lack the physiological properties of resiliency, elasticity, and forgiveness. Now, implant doesn't have that. It's not a living tissue. Implant overload or incorrect loading can lead to a peri-implantitis and bone loss. Often, poor patient occlusal adaptation results from the lack of resilience, which can be followed by the development of muscular disorders and processes structural damage. Implants do not have periodont ligaments, so they have a minimal resilience of 4 to 5 microns, my friends. Unlike the implant which occlude with teeth and implants, so that means a movement of 10 to 35 microns, hence why thin articulating paper is being used, 25 microns. I would like to stress upon you, the resiliency of bone allows about 4, in the literature, this is evidence-based numerical value, 4 to 5 microns it can move, wherein a tooth can move for about 25 to 35 microns. 28 microns is an average. If there are premature contact, interferences, or low overloads, the implants will suffer bone loss, right? A mutually protected occlusion has been considered the ideal occlusal design in implant rehabilitations, right? Right from last 3 decades, 4 decades, it's been proposed, even for natural dentition. But still we see problems, my friends, which is solved by the research proposal by Dr. Robert Kirstein. He is my mentor too, as far as distal occlusion is concerned. Non-simultaneous tooth contact in combined implant and natural tooth occlusion schemes. It's published. It is published in 2002 itself. That is what we are going to discuss and elaborate in the further slides today. What did he say? He suggested a concept called time delay concept. Why is this? Physiologically, when a tooth can move for about 25 to 35 microns, say, and an average around 28 microns, where an implant moves only for about 4 to 5 microns. That is why he suggested this proposal called time delay concept, which we will discuss now. Center of for implant occlusion, these are all the concepts we use. Center of force in T-scan trajectory analysis is what we use basically for full mouth implant supported prosthesis rehabilitation. CO of trajectory we see, which you will see in the screen a little later in the T-scan slides. It is basically on CRCO concept, centric occlusion, centric relation concept. And the force summation should be, it should be right in the midline going from front to back. That's what we discuss about the CO of concept in a full mouth implant rehabilitation. And when it comes to a single tooth replacement, missing tooth replacement, or single implant treatment protocol and multiple teeth missing protocol, time delay concept is what we use, about less than 0.5 seconds. All the natural teeth come into occlusion at one go, and the implant will come into very good occlusion by maybe 10 milliseconds to 40 milliseconds later. That is what we talk about time delay concept. The biometric tools what we have today to measure in dentistry is T-scan for distal analysis of occlusion, joint vibration analysis for checking the temporomandibular joint, and electromyography, whether at resting or functional recordings we make. And of course, we have joint tracker to study the kinesiology of the mandibular movements. But today we are concentrating on T-scan and EMG. So distal T-scan occlusal analysis, the implant occlusal scheme. This is the armamentarium we are going to use. Basically, all the tools I have shown, but this is what we are going to use for checking the occlusion, T-scan and electromyography. So this is how it looks like. And subjectively, when you see the articulating marks, same patient's mouth, look at that. The upper. I wanted to concentrate here for a second. Do any one of us get an idea what is the amount of force delivered by these paper markings and at what time of time, what given time of time? No way, my friends. No way. None of the human eyes can recognize the force against time in this scenario. The only way is thanks to those engineers who have produced this T-scan technology where we can digitize the occlusion and see what is the problem. Couple of cases, glimpses. This is a road traffic accident case. Till anterior nasal spine bone loss, tried in 2 places, then they came in. The third time they were referred to me. We went ahead and finished the processes. Gave a pretty good result. Patient is very happy. But does it go? She's a young lady, probably around 24 years of age, for another 6-7 decades. Today, we don't talk in terms of to my time. It is the patient's lifetime. Can my result go for patient's lifetime? A full mouth rehab case, thoroughly planned with imaging, CBCT imaging, planning for guided surgery, placed implants, one of them a direct sinus lift, and for provisionalization, CAD/CAM milled abutments. This is where the patient came in. This is where we took him on the day 1. Yeah, of course, this was a check X-ray. We tightened all those screws later, and we have given him a provisional CAD/CAM made provisional. After doing so much of work, do I expect in the next 1 or 2 months or 10 years or 15 years any problem with this patient? This patient is just 64, maybe another 3-4 decades of life. We don't want to see any complications later. That is where we use this technology of T-scan and EMG to perfect the occlusion, to calibrate the occlusion in such a way the force delivery against the time is relatively against the time is perfectly matched. That's what we are going to see in a couple of cases. Maybe for some people who don't know what I'm talking about, a T-scan and an EMG, this is what is about the T-scan. It's as simple as this is the hardware connected to your laptop or your computer, and you just ask the patient to bite. The moment patient bites, probably about 10 seconds is what the recordings we take. Here it is not just T-scan, even electromyography is recruited. This is how the leads are connected to the surface electrodes so that you are measuring the masticatory muscles, my friends. Today we are going to the level of objectively measuring the mastication. So this is basically in every clinician eye, you should have T-scan and EMG to check the occlusion and how the force delivery is. The moment you ask your patient to bite, this is how the screen shows on the computer. The software does everything for you. It analyzes and throws it on the computer screen. Yeah, today we have one more advanced tool called intraoral scanner. If you have the scanner, you can straight away scan intraorally the upper and lower jaws, whatever teeth are there or implants are there. Now, the same patient's STL file is incorporated into T-scan software. So this is the kind of advanced science we have. Coming to occlusion, whether it is any kind of restorative work or orthodontic work or perio work, whatever it is picture perfect occlusion, dots at the back as per Dawson's, our peer late Dawson's textbook says, and Dawson says, but patient is not comfortable. Clinically, when I see perfect occlusion, but patient is not comfortable. When I take the T-scan and check in a MIP, maximal intercuspal position, the discharge occlusion shows and tells me patient's left side has 78% of the force and right side 22% of the force. And the 2-7, about 43% of the force on one tooth, my friends, out of 100%. Yeah, this is the other tool, the intraoral scanner we use to scan the teeth, convert the DICOM file into STL file, and incorporate that into T-scan. This is how we incorporate the distal impression STL file. This is, like case history, how we enter. All the details we enter into T-scan software. Once all it is over, we save and then incorporate the STL files wherever you are stored. Browse and incorporate them. So patient's virginal teeth itself is incorporated into the 3D picture of the patient. Yeah, this is the older version. Now today, the first screen in the slide what you saw, that's how it is going to be. This is the 3D and 2D picture in the T-scan data. If you have a distal impression, this gets highlighted. You go click it, you will have patient's own teeth, which will be incorporated into the T-scan software. You can move it in all the directions and orient it perfectly. Then you don't need any media to recognize what is happening on the tooth surface. This is how we incorporate the STL file into T-scan software. Let's move on. He is my mentor, Dr. Robert Kirsten from Boston. 4 decades of his hard work has helped to clear all the myths in occlusion, my friends. Today, not only we are solving problems about teeth, we are solving a lot of systemic issues, which we have been publishing, me, Dr. Robert Kirsten and John Radke, Patrick Giard, Ben Sutter, Nick Yonis. I can take umpty number of about 15 or 20 peers who are working in this research area. migraines, neck pain, shoulder pain, so many things we are helping patients by using this technology. But in today's presentation, I am concentrating on implant occlusion. Yeah, you need to have clear-cut understanding of the physiology and anatomy of our stomatognathing system. And the main kingpin is the trigeminal nerve. So you need to understand the way it travels and the way it supplies all the organs. And if you know that and use this technology, a simple pictorial representation I'm giving you. Now what you're seeing is I asked the patient to bite in MIP. This is the way the muscles are working. That is what we are discussing about neurophysiology. And that Robert Castine has proved scientifically to close our teeth together, to occlude our teeth together, we should be able to do it in less than 0.2 seconds. And to disclude them in excursive movements towards left, right, or forward, we should be able to do it in less than 0.5 seconds. That is the neurophysiology. And after calibration, just watch that. This is a picture of the patient's muscle activity, masticatory muscles, how they're working before and how they're working after. Just a couple of corrections on the teeth using this technology, my friends. This is what we measure. And of course, we have values. Resting, this is in terms of microvolts. Muscle activity is measured in terms of microvolts. And resting and functional activity, there are numbers. And this temporal is way hyperactive. And the moment it is calibrated, look at that. So beautiful it is. It's instant coffee like or instant noodles kind of a result you get when you objectively help your patients. Let's see how we are going to use this technology. This is a single tooth missing case. Patient came in and she's a young kid. Of course, she didn't opt for GBR, except for regeneration of the width, what we have lost to the bone there. She's an emergency bank employee, young kid. We placed a single implant, and of course, I immediately loaded with the provisional. And that's how the implant is positioned. After 3 months, she came back. We went through all the steps, fabricated a crown, and fixed it. Now, what am I doing? I'm measuring what's happening. This is the T-scan data. 1.7 is the replaced tooth. And how the forces are delivered. Now, when it goes into second bite, just check in. Yeah, for those who don't know this, in this graph, the black line is the force line, green and red are representing left and right. A, B, C, D, the first tooth contact is A. By B, all the teeth are together. By C, B to C is MIP. C to D is disclusion time. Now the first tooth contact, afterwards for about 40 seconds, you should not have any force on the implant crown. Now just watch as we move into the second bite. Look at that, right? That's the beauty I'm talking about, my friends. I'm playing it back to one bite at least. Watch that, right? I'm going back. My talk is going to be only on this today, my friends. Look at that. On 1.7 area, I repeat this. I'm going to play this. This should come in contact after 6 and 8 come in contact, right? That is what is the delay, time delay concept is all about. The moment A comes in, the 6 and 8 came into occlusion. Once they are in good bite, then about 30 or 40 milliseconds later, the implant supported crown should come into occlusion, my friends. This is all about time delay concept, and that's how the implant should be loaded. It's not that shim stock or occlusal paper should glide off. It should, the moment you pull off, it should move without any friction. Patient is not coming to us not to have occlusion with the implant tooth, right? Patient comes to us paying and spending time, paying money to have a tooth which is utilized in mastication, my friends. So we need to give a good occlusion. Sorry. Yeah, this is one more case to go through. 19 years old kid comes in with lot of missing teeth. She was referred. The moment she came in, we realized, yeah, she has a distal tooth there. She had gone through about 5 years of orthodontic treatment. Then, of course, once she came in, even I took her through 8 months of orthodontic treatment, a big time, two years work. And I took her through orthognathic surgery. Then we did place multiple implants with biobone management, taking a chunk of bone from the chin area, loaded them, and this is how the patient came to me after 5 years of orthodontic treatment. This can happen anywhere in the world, okay? It's not to talk about or criticize some work. I am talking about a case-based issues. Anterior crossbite, so got it corrected with ortho treatment again, raised the bite, and for that bite, for all the natural teeth, gave lithium disilicate laminates and crowns and screw retained implant crowns. But when it came to, no, I told you, 19 years, and when I finished the work, she was 21. I didn't want to go in for, my dear friends, wonderful job. Patient is very happy. Her parents are very happy. I want this work to go for her lifetime. That is what I'm talking about. That is what we are interested in today. When we do something, it should go for a couple of decades without any issues. That can happen only when you do things objectively measuring. That is what science is all about. Measuring things, objectively doing the things. Beautiful occlusion. I have hundreds of her photographs. Visually, perfect occlusion. But when I took my GAD tools and measured, left-hand side, what you see is the T-scan screen. Right-hand side is a electromyography, EMG screen. Look at the kind of force delivery we have. Perfectly balanced. Visually, I'm telling you, it was perfect occlusion. And even here, distally, when I measure, left and right are beautifully balanced. But what about the kind of force delivery, my dear friends? This is what I want to stress upon. This kind of force delivery, anything beyond blue is a high raised force. Blue are absolutely normal forces. This is what can chip off ceramic. This is what can break down the connector points. This is what can break down your prosthetic screws. And eventually maybe implant failure or implant neck fractures. I have all documented cases, including fracture of the neck. But once we measure like this, it makes you calibrate the bite in such a way, force is balanced and calibrated beautifully against time, right? Look at that. And pictorially, look at the muscle activity, the way the muscles are working here. And after calibration, look at how beautifully they have become functional. This is what we call it as a multi-bite, MIP, maximal intercuspal position. 3 times we have made patient to bite. And now, left and right excursive movements, let's see. Look at the kind of muscle activity you have. And here, this is a left lateral movement. And after calibration, absolute canine guided. Why we talk about canine guidance? My dear friends, for a good, healthy living of any human being, anterior guidance is very, very critical. Even in CRC, OISM from last 100 years is being taught canine guided occlusion. But the fact is, time bound. Can I disclude my teeth in less than 0.5 seconds? That can be measured only by using this technology. That's why we insist time against force delivery can be measured beautifully. Balance it in MIP, balance it beautifully 50-50 or 45-55. And when you occlude and disclude should happen in less than 0.2 and less than 0.5 seconds. This is right lateral excursive movement. Look at the muscle activity and see now. Beautifully anterior guidance or canine guided occlusion. These are the excursive movements. This is a small video showing all the 3 MIPs to make you understand the importance of force delivery. All those forces, what you see, the colors, what you see other than blue, could be a high delivery force. Anything beyond yellow, red, orange, or purple, they are very, very dangerous forces. They can break anything in the mouth. When they can break zirconia, they can break anything else, right? So we are moving into the second bite now. Right, that is the second bite. Let's see, this is how all the 3 bites go, and even the black force line you see, it's quite irregular, isn't it? It's not a clean linear U graph. Patient gives up because unable to take the discomfort in the muscles. Post calibration, look at that force line, beautiful, isn't it? And let's see how the force delivery is. Amazing. 46, 54. You can see the numbers here, right? That's how balanced it should be. A good, well-balanced force delivery. Of course, even in excursive movements, I'm going to show you even the timings in the next slides. For the want of time, I will move on instead of playing the entire video here. That's how we cross-check. One more case. I hope you can see that a single tooth missing is being replaced. This was a temporomandibular dysfunction case who had a 4-6 missing. So we did place a single implant there. As you move, look into this area, probably in the second bite between A and B. At A, any of the natural teeth should come in contact first. About 0.4 to 0.5 milliseconds later, the implant tooth should come into perfect occlusion. I'm just forwarding it so that we move on to the next bite. It's from A to B is what matters in implant occlusion. The occluding time. Yeah, now watch. That's where it goes. That's what we measure. This comes into very good occlusion after a delay of about 0.4 or 0.5 milliseconds. The same case after calibration. Now watch. Even the force line has become so smooth and absolutely U-shaped graph. Now watch as we go into A. Look at that. 4.5, 4.7, now 4.6 came into occlusion. Between A and B, the occluding time, that's when all our teeth should be in pretty good occlusion, my dear friends. This is our excursive movements. That's it. Between A and B. Yeah, if it is a static occlusion, you want to check between B and C. Yeah, you can calibrate. Occluding time is a problem. Yeah, between C and D, excursive movements that can create a lot of problems to a fellow human being in relation to temporomandibular dysfunction issues. That's where we look into the problems between C and D. But for implant occlusion, between A and B is a critical thing. Now look at it after calibration. Look at the force lines become so beautiful. And even the muscle activity has become so nice, right? That was left lateral, just to show an example. This is one more case of an anesthetist who came in. Yeah, first molar was, after an indirect sinus lift, we replaced the first molar with the screw retain processes. This is before calibration. Look at the kind of force raise you have. And there are 3.6 and 4.6 area, there are implants. Let's see after calibration how it works. The next slide. Look at that. So clean U graphs. That itself tells everything is fine. Yeah, by the time slide change, you might have missed the first MIP. As we move into second MIP, I would love to go back one slide and show. Look at this muscle activity. Let me go back. Look at this muscle activity, my friends. This is EMG, how poorly the muscles are coordinating with this kind of force delivery. And look at this. Muscles have become so strong, isn't it? And this is what we call about trajectory of force and COF, center of force. This icon, small diamond icon. This is what is CRCO from front to back. A perfect occlusion and perfect muscle activity. Look at this functional muscles going from 250, 280, 300 and all. This timeline is moving in MIP, maximum intercuspal position. Patient is pretty strong now, but physiologically they are strong. Absolutely, without any interferences. That's when things go perfectly in the mouth. Now in the second bite. This is perfect, As I started learning implants, I've heard so many people teaching us, oh yeah, you should be able to pull out a articulating paper wherever there's implant crown. A easy slide of shim stock leaves. That is not what patient is coming to us, right? We are measuring everything here in this technology. Force against time, relative force against time. And we are loading the implant crown to optimal occlusion with a time delay of about 0.4 to 0.5 milliseconds, my friends. And this is an objective science. It's not because I am saying, right? So that's how things go. This is the same patient's excursive movements. Look at the cavos here. That's why physiologically measuring even the muscles is guiding us how we should be able to proceed with our patient's work. Look at that. I hope you are able to appreciate in the time graph, in the graph of the T-scan image, you see such a perfect U graph, horseshoe-shaped graph. And look at the muscle activity. Just for the love of it, I go back one slide. Look at the weight is going on here. The muscle activity and the amount of force difference, 157, 283, 19, 33. And in MIP, masticatory muscles should be the strongest. It's okay. Look at it. The moment you calibrate, the muscles have become so beautifully synergetical, symmetrical, and the firing time is so wonderful, right? So this is how we measure, make everything perfect. In spite of that, we might see some issues, but this is where it has gone to the zenith of it. Using objectively, using the biometric tools to calibrate and measure and give that comfort to patient. This is the patient's right lateral excursive movement. Same way, look at the force line, it's so haphazard. And look at the way the muscles are working, cavos, it's like city traffic. But after calibration, look at that. This is what I love about measuring the occlusion using T-scan and EMG. Look at this trajectory of force, right from front to back, it is going into the bullseye. That is called CRCO concept. And right there in the midline, beautifully balanced. This is what we talk about, my dear friends. Time delay concept in implant occlusion. Multiple teeth missing. I'll rush through one or two slides. I saw Ruben, so obviously I think I'm overshooting my time. Screw retained processes wherever the teeth are missing and remaining are lithium disilicate crowns. And it's a full mouth rehab case. Wherever you see numbers in red, they're all crown works. Wherever you see I along with the number is an implant present there. So this is how we calibrate. And the same patient after calibration, I'm rushing through this case. Excursive movements, very bad situation. Now, this is called a habitual bite, we call, totally reclined in a supine position, we record and calibrate. One more case of multiple missing teeth, full mouth rehab again. I will not play the video. This is after, beautifully calibrated. I want to show one full mouth case too. So in excursive movements, seeing the graph itself, you can feel, and looking at the muscle activity, you can feel patient is doing very well. Look at the shift from the last slide to here. It's an amazing picture. This is excursive movement towards right before calibration. Look at that after calibration. Wonderful. One more multiple teeth missing situation. I do invariably all now screw retained implant prosthetic work. I usually don't offer cement on work. And this is the most important aspect called force outliers. You press that, it shows where the force is high. An implant 3-5 is very high. So next, the software has all these features. So we look at the force outliers. If the implant processes has very high force, we go and calibrate it. And that's how we calibrate the work. This is one more case. Look at this. Right is so strong, way high, the force delivery. After calibration, the left and right should be well balanced. This is to show, this is at the research end, any clinician can do. You check the force outliers and calibrate them 50-50. I hope you're able to see 49.5 and 50.5 and right there in the bullseye. That's how we calibrate, my friends. This is what is called time delay concept presented to our dental fraternity by Dr. Robert Custine. This is Dr. Prafulla from Bangalore. This is my email ID. You're most welcome, anyone who has any doubts to communicate with me anytime. Ruben, over to you. Thank you very much for everybody's time.
All right, we start with the first question. Sir, how do we check the occlusion if we don't have such an expensive gadget?
The gadget is, financially, I have no answer because it is not expensive for me. It's not that I am rich. I'm an absolutely middle class person economically. And it is not an expensive tool. Probably what you invest, you can get it back in a year's time. That's what I would like to answer for this question. There's no other way.
Thank you so much. So we move to the next.
Cannot recognize these issues without this tool.
Thank you so much. That was
right answer
to the question. We move to the next. So can you explain traumatic graphic picture in multiple tooth missing?
Dramatic graphic picture. All these are, these are screenshots from the software, whether it is T-Scan or BioResearch software. And there is nothing that it's an electronic data. There's nothing that you can edit in that. So it is basically screenshots taken from the software. Because the word dramatic came in, I am saying this, but before calibration, whatever the screens you're seeing, the moment you calibrate using this data, that's how dramatically the picture says, including the muscle activity.
Thank you so much, sir. So can you please give us an approximate cost? That is the next question.
I think today I have an older version, evolution model. Actually, when I bought it, costed me about 8.5 lakhs. Now it has come down to about 6.5. And I bet it helps you so much in our practices in a year or so, we can earn back that money.
Thank you so much. So we move to the next question.
Sorry, when you do full mouth rehabs, where patient is spending 7 or 8 lakhs, I think it is worth using this kind of technology so that you can sleep peacefully as a clinician.
Thank you, sir. Won't the sensor thickness influence with the exact reading?
Zero, absolutely no. Only when the sensor is crushed, it records the data and communicates with the software.
Thank you, sir. Next question. Sir, can you explain multiple tooth traumatographic picture? I did not understand it properly. Why did you start from point E to point B?
Oh, the issue is, it's a beautiful question actually. When we work with implant occlusion, we work, basically the occlusion should be balanced, not just by their contacts, the force against time delivery. Simultaneously from front to back, left to right, the teeth should get loaded. So I mean by occluding. Disclusion time is a different story, MIP is a different story. Here we are talking about implant occlusion. So from A to B, A is the first contact of any tooth. By B, all the teeth are come into contact. So from A to B, when all the teeth are coming into contact by B, so first contact in the first 30 seconds, first 30 milliseconds or 0.03 seconds, all the teeth, natural teeth should come into contact except the implant processes. And by 30 milliseconds, even the implant processes should come into a pretty good occlusion. That is what is called time delay concept. And you can measure this only from A to B while occluding, not when we are in total occlusion or when you are discluding. It should be measured as the teeth come into occlusion. I hope.
Thank you so much, sir. Next question. Will there be upgrading needed for the software every few months or after every year?
No. Whenever there is an upgradation, it's passed on to the client. I mean, whoever is using it.
Thank you. Also, sir, I have a question. What about the patient who already is comfortable with their dynamic individual occlusion? Won't altering it cause muscle imbalance?
The question asked itself is in limbo, because if for subjectively measuring occlusion, subjectively, you might think it is balanced, but on a given tooth, the force could be a very high force, which we can measure objectively with these tools and calibrate them. Subjectively with your photographic pictures, with your eye vision, you can see that it is beautifully balanced, but it is not so in reality.